wanted to do about shunt and VQ mismatch. Before going into shunt and VQ mismatch, you all should know the concept of hypoxia and hypoxemia, so we can understand shunt and VQ mismatch better. And how do we derive the shunt equation? We'll try to keep it short. Don't wanna screen my voice too much. Okay. So what we're gonna talk about today is we're gonna highlight about what is the definition of hypoxia versus hypoxemia. What are the causes and how do we diagnose hypoxemia, different causes. And we will go into a little bit on shunt versus dead space. We have talked in detail about dead space, anatomical versus physiological, and physiological includes anatomical and alveolar. We have talked about the dead space. We'll go to the concept of AA gradient. What is the importance of AA gradient? How AA gradient helps us to diagnose the types of hypoxemia, the causes of hypoxemia. Then we go to hypoxia classification, the pathophysiology of hypoxia, and a bit of bedside calculation, as in ABG analysis. How do we actually, no need to go through the extensive formula and everything. What are the simple method we can calculate by bedside to actually diagnose the hypoxemia types of hypoxia? The shunt equation and VQ mismatch, I will leave it for next topic. So the core recipe today, as I mentioned, we're going to talk about hypoxia versus hypoxemia. It just one is the subjective value of numbers. Another one would be the effect of the low oxygen, which is hypoxia. Okay, there are type of hypoxemia, can be 5 causes. The main causes of hypoxemia are divided into 5, whereas hypoxia classified into 4 different types of hypoxia: hypoxemic, stagnant or circulatory, anemic, or histotoxic or cytotoxic. So we'll go into this again later. So some quick recaps about last week. We talked about different types of partial pressure of oxygen, all the way from the atmosphere until the alveolar and arterial blood. So to calculate partial pressure of oxygen in atmosphere, we simply times FiO2 times the atmospheric pressure. We get 160 millimeter mercury. In a healthy individual who inspiring room air, we have to times the FiO2 times the pressure atmospheric minus the saturated vapor pressure. So 0.21 saturated vapor pressure, we know the value is around 47 in a healthy human adult at room air and at sea level. So 47, so you get around 150. So there's a drop of 10 millimeter mercury from atmospheric to the airway. From airway to alveolar, you have your alveolar gas equation where you calculate your PiO2 first, this part, FiO2 times pressure atmospheric minus SVP minus partial pressure of carbon dioxide, which we can get from ABG. It's supposed to be alveolar CO2, but it's equivalent to arterial CO2 because of the Enghoff modification. I've talked about it last week, divided by respiratory quotient. We also talked about what is respiratory quotient last week. So in a healthy individual, you take a normal ABG or PCO2 of 40 divided by respiratory quotient of 0.8 for a balanced diet, you're going to get 100 millimeter mercury. So there's a drop from 150 to 100 millimeter mercury. Then followed by PaO2, we can measure directly from your arterial blood gas analysis, which is normally in a healthy individual inspiring room air would get around 90 to 95 millimeter mercury. The drop 100 to 90 to 95 millimeter mercury is because of the venous admixture. We have talked about it, okay? So this is just recap. So today we're going to concentrate from all this all the way to cellular PO2, okay? So oxygen cascade, that's why I started my topic with oxygen cascade first, then went into this topic, then we go into shunt and everything later on. So the drop in PO2 at each level is because of different reasons, okay? So we come to topic today, hypoxemia versus hypoxia. So what is hypoxemia? Semia means when you know whenever there's something got semia, let's say septicemia, you want to talk about anything, it's all about in the blood. So what is hypoxemia? Is low partial pressure of oxygen in blood. So this is low PaO2. While hypoxia is low oxygen supply or low oxygen level at tissue level, at cellular level. Okay, not in the blood, it's at the cellular level. Your cells usually with adequate oxygen undergoes aerobic respiration. So they need aerobic respiration. In your cell, there is electron transport chain, which uses oxygen as a substrate. There is oxidative phosphorylation. So there's all these things that occurs at your cellular level by mitochondria under aerobic situation. So hypoxemia, the PaO2 we can measure directly in ABG, but hypoxia, we can't measure the hypoxia level directly. There is no number for hypoxia. So what we do, hypoxemia, the PaO2 less than 80 millimeter mercury taken as hypoxemia. Okay, we'll come to the classification of severity of hypoxemia. Of course, in our setting as a respiratory failure, we take a PaO2 of 60 millimeter mercury. That is based on the oxygen dissociation curve. But hypoxemia is classified as mild even below 80 millimeter mercury because of this. I've talked about it here. In a normal patient, in a normal healthy individual who inspiring room air, you get around 90 to 95. We can give a leverage of another 10 up to 80 millimeter mercury where we say patient does not have hypoxemia. But the PaO2 is less than 80, we will diagnose the patient as hypoxemia. So what are the causes? Then we have to find out. Whereas in hypoxia, we can only quantify hypoxia as one of the indirect measurement of hypoxia is lactate, because lactate is a byproduct of anaerobic respiration. When the tissue level in your cells at the mitochondria is very low, we usually have a word called pasture point. It goes up to the mitochondria and etc have a very high affinity for oxygen, where they can extract oxygen at the level of pasture point up to 2 millimeter mercury. So if the oxygen level drops even below that, at a very significantly low level, then your respiration will switch from aerobic to anaerobic respiration. And lactate is a byproduct of anaerobic respiration. Thus, increase in lactate may indicate there is an anaerobic respiration going on and patient is in hypoxia. Okay, so hypoxemia is a defect in external or internal respiration. We talked about what is external, internal. This is all the way from oxygen inhalation. You gas inhalation, you inhale the air, all the way goes through the airway and reaches your alveoli. There's a gas exchange of my alveoli, which goes through your capillary alveolar membrane to your capillaries and bypassing the capillary membrane. This is just hypoxemia is the defect from the atmosphere all the way the blood reaches alveoli and get transferred into the pulmonary capillaries. Whereas hypoxia is at the cellular level, okay, at the cellular respiration. There is no problem with the flow. There is this problem in the defect in cellular respiration could be because of defect in oxygen uptake or oxygen delivery or oxygen utilization. It could be either. Whereas in hypoxemia is all low oxygen intake or defective oxygen exchange. This is at initial level. This is at the final level. So hypoxemia, the problem could start from inspired oxygen being low, then alveolar oxygen being low, thus the PaO2 being low. Whereas hypoxia could be this, hypoxemia leading to hypoxia, plus the hemoglobin can be an issue, can oxygen flux, it means the flow can be an issue, which is a cardiac output, plus your electron transport chain. The cells that utilize the oxygen can be problem. They do not always coexist. Doesn't mean patient with hypoxemia will develop hypoxia or patient with hypoxia will develop hypoxemia. They not always coexist, but they may coexist. As an example, patient can develop hypoxemia without hypoxia. Mean patient can develop hypoxemia without hypoxia if there is a compensatory increase in hemoglobin level and cardiac output. Because as I say, hypoxia, oxygen flux is one of the factor. So what is important in oxygen flux is your hemoglobin level, your cardiac output and everything, and also your PaO2. But let's say your PaO2 is low because a patient is having hypoxemia, but there is a compensatory increase in hemoglobin level and cardiac output, that patient might not develop hypoxia. A classical example is people living in altitude. I have told you FiO2 remains the same at sea level or at a high mountain like Mount Everest or anything. What changes is the atmospheric pressure. At high altitude, the atmospheric pressure is low, thus the PO2 is low, thus the PaO2 is low, thus the arterial O2 is low. So patients are hypoxemic, but patient will live high altitude where they have very high hemoglobin level, they have compensating increase in cardiac output, thus maintaining the oxygen flux, which is the delivery to the cells, thus they don't have hypoxia. So that is a classical example. It can be a vice versa also. They can be hypoxia without hypoxemia, as in cyanide poisoning. In cyanide poisoning, there is no problem with partial pressure of oxygen in the blood, but the problem relies in the tissue itself. We mean there is enough delivery of oxygen to the cells, but the tissues cannot utilize the oxygen. So patient does not have hypoxemia, but they can develop hypoxia, which is cytotoxic hypoxia. We'll go into this later. So again, recap, you have external respiration, which is blood is you breathe in the air, goes into your trachea, goes into your alveolar bronchioles, and goes into alveolus. From your alveoli, it passes through your capillary gas exchange, internal respiration. Problem here, and then finally from the blood, from the oxygen that is transported in pulmonary capillary, goes through systemic circulation, reaches your cells for cellular respiration. Problem in external and internal respiration will call hypoxemia. Problem that causes cell delivery or oxygen delivery or oxygen utilization for cellular respiration causes hypoxia. So classification of severity of hypoxemia, more than 80, 81 and above we consider as normal. 80 to 100 is normal. 60 to 79 we consider as hypoxemia, mild hypoxemia. 40 to 59 would be moderate hypoxemia, and severe would be less than 40. But in respiratory failure, we take moderate hypoxemia. Type 1 respiratory failure, PaO2 less than 60. So this. So moderate hypoxemia is the cutoff line. We take it as a respiratory failure, as in for oxygen dissociation curve, where your SpO2 will drop drastically. So we look at it here. Normal SpO2 can maintain more than 95%. Even at mild hypoxemia, we can still maintain SpO2 of more than 90. But PaO2 less than 60 only, your SpO2 drop drastically up to 75. That is why we take respiratory failure cutoff point or ICU point as PaO2 of 60. And severe would be less than 40 millimeter mercury. So this is an healthy individual less than 60 years old age at sea level. Okay, this is the values that we classify severity of hypoxemia. So causes of hypoxemia. To make it simple and easy to understand, these are the 5 common causes that always and most of the books mention and make sense as well. So first, you have a normal patient with a normal airway, normal alveoli, and normal perfusion. This is your capillaries, pulmonary perfusion, so normal. So what can go wrong that can cause us hypoxemia? Number 1, hypoventilation. You are breathing less. Means either you have bradypnea, your respiratory rate is low, or your tidal volume is low. We talked about minute ventilation. Minute ventilation is tidal volume time respiratory rate. So either the minute tidal volume is low, you're taking a very shallow breaths, or your respiration is low. Bradypnea could be multiple causes. So that causes hypoventilation, thus less alveolar gas can cause us hypoxemia. So less alveolar gas, less oxygen, less partial pressure of alveolar oxygen, thus can cause us low in PaO2, so hypoxemia. Next, less FiO2 itself. So as we have talked, most of the FiO2 remains the same at all atmospheric level. But if the patient goes into an area or patient go into a closed space, as in cave, or patient goes into a closed space as a confined space, underground, anything where the FiO2 is much lesser, then of course, when FiO2 lesser, your PiO2, PaO2, everything will go down. So this is self-explanatory. Next, we talked about dead space last week. So when there is a dead space ventilation, it means there is ventilation without perfusion, okay, which is a wasted ventilation. The oxygen goes through from your airway, from atmospheric to your airway into your alveolus, but that alveoli are not being perfused. So this ventilation, this gas that goes there does not take part in gas exchange. That space we talked about, there are space that occupies the air that does not take part in gas exchange. So that there is no gas exchange, of course there will be hypoxemia. So this is another reason why we saw as VQ mismatch. VQ mismatch actually involved dead space and shunt. Because shunt, we have another one there. I put VQ mismatch as here. Next, we have shunt. Shunt is opposite of dead space, as in there is perfusion without ventilation. So the alveoli are getting enough perfusion from the pulmonary capillaries, but the alveoli is not being ventilated. It means there is no gas that going to the alveoli. Could be because of atelectasis, good of fibrosis, or the any problem with the alveoli itself, parenchyma. Okay, so there is perfusion, but there is no ventilation. That's called shunting. Okay, that is number 4. Finally, we have diffusion abnormality where your ventilation is okay, your perfusion is okay. The alveoli are getting enough gas and there is pulmonary capillary perfusion is good. But there is thickness or there is problem in the alveoli parenchyma itself that causes defective gas exchange. We talked last week, your oxygen and CO2 are passive diffusion. Gases follow fixed law of diffusion where they move from higher partial pressure to lower partial pressure. Okay, and they move fast or low according to your solubility coefficient. CO2 being highly soluble compared to CO2. CO2 crosses the alveolar membrane, then pass through the capillary membrane, reaches your blood much faster and reaches equilibrium in a much faster manner compared to oxygen. But oxygen, the partial pressure gradient is very high compared to alveolar to pulmonary capillary. Thus, oxygen transport also across the alveoli to pulmonary capillary is faster. So any factors that involve in your fixed law of diffusion, as we talk about the surface area, we talk about thickness, we talk about the partial pressure gradient and solubility coefficient, all these can affect the diffusion. So these can affect the defective gas exchange. So these are the 5 causes of hypoxemia. So again, repetition, we talked about. This is a talk about VQ mismatch. So diffusion, I already talked here. When you have hypoventilation, there will be reduction in VQ, okay, because V is less. Up is V, below is Q, V divided by Q, ventilation divided by perfusion. So hypoventilation, of course, VQ will be low. In a normal, V to Q is 1 or 0.8 around there. In that space, V over Q, Q is 0. There is no perfusion. So anything divided by 0 will get 0. Okay, and diffusion. And in terms of V over 0, there is ventilation. Sorry, there is no ventilation, but there is perfusion. Okay, so 0 divided by anything, you will get infinity and everything. Actually, the Q is 0, V is 0 here. Then we can get VQ mismatch either infinity or 0. We come to VQ mismatch in detail later. Before this is just to show you how each of these causes of hypoxemia differs in VQ. So the pathophysiology we talked about. So low FiO2, we follow the low FiO2 and hypoventilation both cause reduction in pulmonary, partial pressure of alveolar O2. So this is your alveolar gas equation. So the alveolar gas equation, as we discussed, it is affected by the inspired fraction of oxygen. It is inspired by the atmospheric pressure, and it is affected by the also the PaCO2. So in low FiO2, FiO2 is low. So of course the PaO2 will be low. Okay. In a patient who are having hypoventilation, when somebody is hypoventilating, what we know, there will be CO2 retention. So the PeCO2 will go up. So when PeCO2 goes up, your PaO2 will be low. When your partial pressure alveolar is low, then your partial pressure of arterial oxygen will be low as well. Excuse me, just 1 minute. Okay, that's about low FiO2 and hypoventilation. Diffusion limitation, it follows fixed law of diffusion. The concentration gradient or partial pressure gradient, surface area, and membrane thickness. In a patient with pulmonary lung, interstitial lung disease where they have alveolar fibrosis, the membrane is thickened. Thus, the rate of diffusion is lesser. So thus, the PaO2 will be less. Then we talk about VQ mismatch and shunt, either is dead space or shunt itself. Okay, all these are pathophysiology of hypoxemia. So how do we diagnose hypoxemia? First, hypoxemia is classified. You take an ABG, a person, healthy person, breathing room air. You take an ABG, the PaO2 is less than 80 millimeter mercury. Okay. So how do we want to know what is the cause of hypoxemia? We have these 5 causes of hypoxemia. Which is the reason? What is the reason out of these 5? Which one is the reason for this hypoxemia? So that's where the concept of alveolar arterial oxygen gradient, where we call it AA gradient, comes in. A gradient simply is partial pressure of alveolar oxygen minus partial pressure of arterial oxygen. How do we get a partial pressure of alveolar oxygen? We do alveolar gas equation, or and then we get a ABG, we get a PaO2, which is here. We already get it here. So minus this and this, we get a value. The normal value is less than 20 millimeter mercury. Different books give different numbers, 5 to 15, 5 to 20, 5 to 22. But most books and most of the authors take less than 20 as a normal. Because as I talked earlier, sorry, we just back a bit. Here, we know partial pressure of alveolar oxygen is 100. And hypoxemia, we take it as 80 millimeter mercury. So 100 minus 80 is 20. So 20 millimeter mercury will be taken as a normal AA gradient. Anything more than that, the differences, which is taken as widened gradient. So when you do, we'll come to the formula of AA gradient and the bedside formula shortly. Before that, just this flowchart first. When a patient has a normal gradient less than 20 millimeter mercury, it could be because of hypoventilation or low FiO2 or low PiO2. Because when a patient is hypoventilating, your PaO2, alveolar oxygen will be low, and your arterial oxygen also will be low. So both low, the gradient won't be bigger. Same goes to FiO2 or inspired oxygen. When the FiO2 is low, the partial pressure of alveolar oxygen also will be low, and in turn partial pressure of arterial also will be low. Thus, there is no differences. There is no widening of this A gradient because both are equally dropped. The widening occurs more when there is a significant increase in PaO2 or significant drop in P arterial O2. So that is the widening gradient. So when does this happen? When you calculate your A gradient, if it's more than 20 millimeter mercury, we either think of VQ mismatch, diffusion limitation, or shunt. So these are the 5 causes we have. If there is normal gradient, you think of hypoventilation or low FiO2 or low PiO2. Or if it's widened gradient more than 20, you think of VQ mismatch, which is dissipates, diffusion limitation, or shunt. How do we know which these or these? How do we divide? How do we actually distinguish between these and these or these three? We'll come to the much more another flowchart soon. Before we go into that, a brief discussion on dead space versus shunt. I've talked about it a few slides earlier, but just to go again, repetition. So shunt is when you have a alveoli or when you have a unit that is being perfused but not ventilated. Whereas dead space is you have a alveoli being perfused but there is no blood flow. Okay, here problem is ventilation. Here the problem is perfusion. Okay, that is the difference. Dead space mean problem with the perfusion, whereas shunt mean there is problem with ventilation. Okay, there's a difference between these two. And VQ mismatch, we look at normal. When you look at normal, in normal patient, V in Q is normal. So you get a value of 0.8. We don't get value of 1 because of different zones of our lung, apex, middle, and base. That we will discuss extensively when we talk about the physiology of the anatomical physiology of lungs and different zones later on. And I will touch on it when we talk about shunt and VQ mismatch in the next class. So when we have dead space ventilation without perfusion, what happens is you have V, but Q is 0. Anything divided, you'll get an infinity number. You have to know this, can come out in MCQ. But in case of shunt, there is perfusion, but with no ventilation. Either it's a mucus plug or alveolar collapse or whatever it is. So 0 divided by anything, you'll get 0 as well. So these numbers, you must know, they can come out in MCQs. So the concept of AA gradient, before we go into diagnosis of hypoxemia, to how do we distinguish even between the normal and widened AA gradient, what do we do actually to find out? So the AA gradient, as I mentioned, P alveolar O2 minus P arterial O2. How do you get your P arterial O2? We measured by our ABG. Alveolar O2, we will calculate using alveolar gas equation. That is simplified manner we can do bedside. That are all shortcut. We will come into it at the end. Now we do the we learn the proper way. So we have talked about alveolar gas equation last week. So you get all this value and put in all this information, you get this alveolar equation. Alveolar partial pressure oxygen, then you minus this, you will get normal value 5 to 15. We take it as less than 20 millimeter mercury. Why? I've mentioned it here. The drop from alveoli PaO2 to arterial PaO2 is usually around 5 to 10. We can give the range up to 20 millimeter mercury, the drop from 100 to 80. Okay, because arterial PaO2 less than 80 millimeter mercury only, we take it as mild hypoxemia, the start of hypoxemia. Okay. Another way of calculating alveolar arterial PaO2 gradient, let's say you don't, before even you calculate, okay, you want to know what is the expected for this patient versus what is the actual. A person is intubated and admitted to your site. So what is the A gradient that is expected for this patient? It's age divided by 4 plus 4. Usually that is the expected. Because your A gradient is affected by age, there is increase in A gradient. The difference between alveolar to arterial increase for every decade of a aging patient. Because there is change in lung parenchyma, there will be diffusion limitation, there will be reduction in the gas exchange and everything. Thus, there is partial pressure alveolar oxygen and partial pressure arterial oxygen, of course, there will be increase in differences. The gradient will increase. So we can calculate. Let's say a patient with 80 years old, okay, 60 years old admitted to your ICU. 60 divided by 4 is 15 plus 4 is 19. So up to 19 millimeter mercury of A gradient is normal for this patient. Okay, that's how we calculate. Age divided by 4 plus 4. Let's say a 40-year-old patient admitted, 40 divided by 4 is 10 plus 4. So up to 14 millimeter mercury of A gradient is normal for this patient. So this is bedside calculation. So you calculate this first, then you take an ABG. Okay, you take an ABG, you do your alveolar gas equation, you get your value from this, and then you see. Let's say this value is, we get it for 40-year-old, just now we said it's 14, but here it's only 10 millimeter mercury. Thus, there is no increase in A gradient. But when you calculate here, this person have a very high gradient. So that could be because of the increase in A gradient because of hypoxemia or any other causes that we have to find out. But bear in mind, these values are for patients who are breathing room air most of the time. Okay, these all are used in patients who are coming into your ED, patient coming into your initial presentation. When the patient is in oxygen supplementation, we have to actually wisely have to interpret all these things. Okay, you cannot be because of course, let's say patient is already ventilating with the 60% of your FiO2. Your PaO2 will be in 200s or 300. But when you calculate your PaO2, this also will go up as well because you are giving high FiO2. Your partial pressure alveolar oxygen is, the equation say FiO2 times pressure of atmosphere minus SVP minus PaCO2 over respiratory quotient. So you have to do this to whether you can get a almost similar number, or if it's increased, then you have to find out what are the causes of hypoxemia. How do we find out the causes of hypoxemia? We come to the next slide. So I recommend you all go back to your work next week or anything, take an ABG, look at the patient FiO2, do this simple alveolar gas equation, then calculate the A gradient, then you can somehow come into a conclusion what type of hypoxemia is that. Then you check back with your diagnosis. Is the actual diagnosis fits into your calculation? So we have looked at this chart now. So how do we actually determine if it's a normal gradient? Is it because of hypoventilation or is it because low FiO2? If it's a widened gradient, is it because of VQ mismatch, diffusion limitation, or shunt? So to differentiate the causes of normal gradient in hypoventilation, as I said, there'll be CO2 retention. So the PCO2 will be high. So thus you can differentiate between this and this. If there is normal gradient with a normal PCO2, most likely it's low FiO2. But if it's a normal gradient with high PCO2, that will be hypoventilation. That is simple for normal gradient. Okay. Then another way we can actually differentiate whether it's what are the causes. We give 100% oxygen. The response to 100% oxygen. Okay. The response will be good in a patient breathing hypoventilation, patient breathing a low FiO2, obviously.
or patient having a VQ mismatch. Because V over Q, right? You increase your FiO2, the ventilation part of your equation is going up because of high FiO2. So the VQ mismatch will improve. You have a diffusion limitation. As I said, when you get FiO2 of 100, you are increasing your partial pressure alveolar oxygen. Thus, the difference in partial pressure is higher. According to Fick's law of diffusion, higher the partial pressure gradient between two areas, faster the diffusion, increase in gas exchange. But poor in shunt. If it's a shunt that causing the hypoxemia, when you give 100% oxygen, there not be any significant increase in PaO2 or there'll be none increase in PaO2, depends on the severity of the shunt. So when you give 100% oxygen, if there is a good response, you can think of all this. This four. When there is no response or poor response, you think of shunt. Okay. And between the normal gradient, hypoventilation and low FiO2, you look at the PCO2 to divide. Between VQ mismatch and diffusion limitation, it's all about patient presentation and underlying symptoms and everything. We have to look at it in a more, we have to relate with other clinical pictures. So again, this is another flowchart explaining the what we have talked, including with few examples of clinical situation where it can happen. So we have hypoxemia, we calculate our A gradient. The A gradient is normal or high. In a normal A gradient, it could be low FiO2 or PaO inspired PiO2 or hypoventilation. As I mentioned, how to differentiate these both two, hypoventilation will have an increased PO2. Low inspired PO2 because of high altitude. In high altitude, FiO2 is the same, but the PiO2, P inspired oxygen, partial pressure inspired oxygen will be low because of drop in atmospheric pressure. So that is the classical example here. So in hypoventilation, what are the causes of hypoventilation? Hypoventilation is drop in minute ventilation. It could be low tidal volume or low respiratory rate. It could be central causes or peripheral causes. Central causes could be drugs. Most commonly what we know is as opioids, or coma due to hypoglycemia, thyroid myxedema coma, or patient with any central depressants drugs, or hypothyroidism. All these are central depressant of respiration, which is called hypoventilation. When you have peripheral usually is not about the rate, it's about the volume. Central is mostly volume and rate, both, but rate is more affected. They will bradypnea most of the time. But peripheral is mostly about the volume, which is because of obesity hypoventilation syndrome, neuromuscular weakness, pleural abnormalities, or chest wall abnormalities. Okay, so all these are hypoventilation. What are the causes? So do we know in all these situations, patient will retain CO2. Okay, so then we go to IA gradient or widen A gradient. We have shunt, VQ mismatch, and diffusion limitation. Diffusion limitation, as I mentioned to you, is interstitial lung disease or occupational lung disease, sarcoidosis, asbestosis, patient with alveolar fibrosis, scarring, those who had COVID, severe ARDS, pulmonary arterial hypertension. All these are diffusion limitation. In pulmonary arterial hypertension, it's a problem with the capillary. Okay, the diffusion problem is at the capillary side, whereas in interstitial lung disease, the diffusion problem is at the alveolar side. We have alveolar membrane, we have capillary membrane. Okay, so diffusion is the oxygen has to pass through alveolar membrane into your capillary membrane into the blood. Whereas in VQ mismatch, we know either there's a problem with the V or the Q. So V can be airway diseases, perfusion could be because of vascular pulmonary embolism or parenchymal disease. Shunt, mostly what we think about is the right to left shunt. Right to left shunt is the one causes oxidation problem. Left to right shunt, most of the time does not cause, because as the patient who have most of the time our systemic circulation pressure is higher than the pulmonary circulation. So most of the patient, even with the congenital heart disease, they have left to right shunt. But once it becomes right to left shunt, it goes into Eisenmenger. That is the severity, severe one. Okay. So the right to left shunt could be because of intracardiac or pulmonary. Intracardiac could be ventricular septal defect or atrial septal defect, or pulmonary could be AV malformation, severe pneumonia, atelectasis. These are the causes of each hypoxemia and what are the clinical situation they can get. So these are the 5 different causes of hypoxemia. These are all the clinical situation where they can develop this hypoxemia. So there is another ABCD approach. Let's say you are doing a case in OT and the patient, you take an ABG, patient hypoxemia, you can always go to the ABCD approach to find out what could be the problem. It all goes back to the 5 causes of hypoxemia, but these are the approach that you have to take to identify or troubleshoot what could be the reason for this hypoxemia. So airway, you can look at about this all these things. I'll leave this slide here, or I'll share this slide in the group as well, so you all can have a look at it and keep it as a reference, quick reference. So everything to do with the airway lah, from the ETT all the way up to the patient's airway, engine secretion or whatever can be. Breathing could be hypoventilation, high spinal pneumothorax. Circulation could be hypotension or hypovolemia. Drugs that causes anesthetic drug leading to apnea, anaphylaxis, inadequate reversal of muscle relaxant, deep anesthesia, or equipment. Equipment issues could be all these failed oxygen supply causing low FiO2, anesthesia machine causing inadequate ventilation setting, this circuit problem causing reduced flow of the gas into the alveoli, or faulty pulse oximeter. So why we talk about pulse oximeter? I've talked about the hypoxemia. Hypoxemia severity can be, we can classify under the PaO2, but there is a subjective or easier way looking at SpO2 also. We can say patient have hypoxemia because PaO2 correlate with your SpO2 as per oxygen dissociation curve. So the bedside calculation, as I promised, first, how do we calculate expected alveolar oxygen for a person who breathing certain FiO2? Okay. What we usually do, the proper way is using alveolar gas equation, the full equation. But bedside, you can just calculate 7 times FiO2 in percentage minus the BCO2. Let's say a patient is being ventilated with FiO2 of 0.6, which is 60%. Okay, and you take an ABG, the person have the PCO2 of 45 millimeter mercury now. Okay, 7 times 60% is 420. 420 minus 45, which is around 375 if I'm not mistaken. Okay, let's put it at 40 lah. So you get 380. That is your alveolar partial pressure oxygen. 7 times 60% of your FiO2 minus the PCO2 that you get from your ABG. This is the person being ventilated. Okay, then how do we calculate PaO2 on room air? This is by the age. Okay, if you're going to intubate a patient, before they refer you for a patient for intubation in the ward, you go see, they have taken the ABG, they think patient is being tachypneic and everything. This is the ABG before we put on oxygen supplement. For that patient, usually the expected PaO2, arterial O2 on ABG under room air should be 100 minus age divided by 3. If the person is 60, 60 divided by 3 is 20, so 100 minus 20, you should get PaO2 of 80 millimeter mercury for the patient. Okay, if the patient is 20 years old, 20 divided by 3 is around 7. So 100 minus 7, you should get around 92 to 93 under room air. Okay, if it's anything below than that, patient is hypoxemic. If the patient is on oxygen, this is on room air. If the patient is on oxygen, you have to time 5 times FiO2 percentage. Okay, this is 7 times FiO2 minus PCO2 for alveolar. For arterial is 5 times FiO2. Okay, so again, the patient is put on ventimask 40%. Okay, now the patient is ventimask 40% of oxygen. You are called for intubation. You want to know whether the patient is actually hypoxic or not. So 7 times 40. 7 times 40 is 280, and your PCO2, let's say, is 40, 240. And then you put 5 times 40 here, you get around 20 millimeter. 5 times 40, you get around 200 millimeter mercury. Okay, so that's how we calculate and see. So here, when you see these two, if you take these 7 times 40, 280 minus 40, 240. Here, 5 times 40% is only 200%. So there will be a difference in AA gradient of 40 millimeter mercury, right? So that's why I say these are just bedside calculation. So, but where do we get this PaO2 normally? We will get it from our ABG itself. This is for you to see just rough idea how much they should get. But this is not always accurate for sure. Okay, when you go for a basic ICU course, they teach all this calculation for just for your quick reference to see. But if you want to calculate proper AA gradient, you have to use the PaO2 from ABG. But since you don't want to do your alveolar equation in extensively by bedside, you can follow this. Okay, so follow this, and then you take the PaO2 from your ABG, and then you calculate your AA gradient. AA gradient we already talked about. It's H divided by 4 plus 4 is the expected for a patient, and the normal is less than 20 millimeter mercury. We come to hypoxia. Hypoxia, there are 4 types of hypoxia. So we already discussed the distinguishing factor between hypoxemia and hypoxia is hypoxemia is low PaO2 in the blood, whereas hypoxia is low oxygen delivery or usage in cells. So the 4 different types of hypoxia could be hypoxic hypoxia or hypoxemic hypoxia is the same. Means hypoxia because of the low PaO2, anemic hypoxia, stagnant hypoxia or histotoxic hypoxia. Stagnant hypoxia is also called circulatory hypoxia. It means there is a problem in the flow. The flow is stagnant. Or histotoxic hypoxia, also called as a cytotoxic hypoxia, which is the problem is in the cell utilization of oxygen. Okay, these are the 4 different types. So hypoxia is the defective oxygen exchange. Sorry for the typo. Defective oxygen exchange. Anemic hypoxia is the defective oxygen carrying. Stagnant hypoxia is the defective oxygen delivery, and histotoxic hypoxia is the defective oxygen usage. So we know a patient can develop hypoxia because of all these problems. So simply put, hypoxemic hypoxia is the oxygen exchange at the alveoli level, which causing low PaO2 in the artery. Anemic hypoxia, there is no problem with the PO2. The problem is in the oxygen carrier. Oxygen carrier is your hemoglobin. So the hemoglobin is the problem. Blood flow is the problem in circulatory hypoxia, whereas oxygen use is the problem is in the histotoxic hypoxia. They might exist as a single pathology for causing hypoxia, or they may coexist. A person can be anemic and person can be hypotensive as well, causing hypoxia. A person can be hypoxemic because of 5 causes of hypoxemia just now, plus anemic as well, causing hypoxia. So they may coexist. So look at this. I found this picture that I found in Google. Is very good. I will share this in the WhatsApp group just in a while. So we have a normal person breathing oxygen. The oxygen goes from your trachea, your bronchioles, goes to the alveoli, then gas pulmonary exchange, goes into your blood vessel. We know oxygen is delivered in your blood vessel as in bound to hemoglobin, as in dissolved in plasma. This is our first class. We talk about oxygen delivery. Oxygen delivery is oxygen content in blood. Oxygen content in blood is divided into that once that bound to hemoglobin, this part, oxygen bound to hemoglobin and oxygen dissolved in plasma. So this equation all we discussed before. And then the oxygen delivery is simply the oxygen content that we get from here times with your flow, which is your cardiac output. So in a normal patient, hemoglobin is normal, the SaO2 is normal, it goes to the cells in the mitochondria, it goes through the electron transport chain, the electron transport chain is working well, oxidative phosphorylation occur, so there is no hypoxia. So in hypoxemic hypoxia, the problem is in the PaO2. There are 5 different causes why a patient can develop hypoxemia. It could be any of it. Thus, the PaO2 is low. When the PaO2 is low, we know oxygen dissociation curve, SaO2 is equivalent to PaO2. Here, SaO2 is the saturation. Here, SO2 is the solubility of oxygen. We already discussed 0.03 mil of oxygen is dissolved in plasma per millimeter mercury of oxygen. Okay. So when PaO2 is low, oxygen dissociation curve, SaO2 also will be low. So of course, the oxygen content will drop. Thus, even though the flow is normal, the oxygen delivery will be dropped. So that is hypoxemic hypoxia. Then we go to circulatory hypoxia. Circulatory hypoxia, there is no problem with the oxygen content, but there is a problem with the flow. The flow is low. Either the BP is low because of hypotension, or there is embolus, thrombus, there is obstruction. So circulatory hypoxia, circulatory could be because of any shock. We will come into it. What are the types of shock in a while? Circulatory hypoxia is because of shock. Shock can be different various types of shock. Okay. Then we have anemic hypoxia. Anemic hypoxia is the problem with the hemoglobin. Again, it goes to oxygen content, this formula. Your PaO2 is normal, your SO2 normal, but your hemoglobin is low. When your hemoglobin low, your oxygen content will be low. Even though your flow is normal, your oxygen content low, your oxygen delivery will be low. Patient can develop hypoxia. Finally, we come to histotoxic hypoxia. There is no problem with the oxygen content. SaO2 is normal, PaO2 is normal. Hold on, just give me a moment. Okay, so this part of it, we know the oxygen content is normal. We know the PaO2 is normal. We know the flow is normal. But the problem lies within the cellular level. There is a problem in the electron transport chain, which cannot utilize the oxygen that is being delivered. Thus, the cell undergoes anaerobic respiration because whatever the oxygen being delivered, it can't be utilized. They can't undergo through this electron transport chain. Oxidative phosphorylation fails. That is histotoxic hypoxia. So again, how do we diagnose each of it? Respiratory or hypoxemic hypoxia, I've talked about it just now. We give 100% oxygen. If it responds well, we know under VQ mismatch, diffusion impairment, FiO2 hypoventilation. And based on PCO2, we know it's low FiO2 hypoventilation. If does not improve much or there is no improvement, it could be a large shunt. Other types of hypoxia, cardiac or stagnant hypoxia, could be because it's a delivery issue because of the flow. In this, normal PaCO2 related to cardiac output results in reduction in venous oxygen and venous saturation of oxygen and your venous partial pressure of oxygen. Okay, from increased tissue extraction of your oxygen, because there is less oxygen being sent to the patient, sent to the cells. Whatever they have, they extract. So the venous oxygen will drop even further. So response to FiO2 of 100% does not much because look at it. The problem is with the flow. When you increase the FiO2, it only increases the content. The content increases, but the flow is not much increase. So the flow, the response to 100% oxygen won't be much. Blood and tissue hypoxia, where it's because of anemic and histotoxic, it's because the patient will have a normal PaO2 and normal flow. But the anemic hypoxia, the oxygen carrying capacity of the hemoglobin is dropped because either reduction in hemoglobin or malfunctioning in hemoglobin. Thus, and histotoxic hypoxia, the oxygen use is defective at the cellular level. The response to 100% oxygen. If it responds to 100% oxygen, we know it's because of carbon monoxide poisoning. It's a competitive inhibition. We know carbon monoxide has 240 times higher solubility or affinity to hemoglobin compared to oxygen. Thus, in carbon monoxide poisoning, the carbon monoxide will displace the oxygen from the hemoglobin. Thus, the hemoglobin are considered to be malfunctioning. So when you give 100% oxygen, you increase the FiO2, means the partial pressure of oxygen will tremendously increase. Thus, it can competitively compete with the carbon monoxide, so the place in the hemoglobin. If does not increase, it could be purely reduction in hemoglobin and more methemoglobinemia, or in cyanide poisoning. In cyanide poisoning, the problem is not with the oxygen delivery or oxygen concentration. The problem is within the cell itself. That is histotoxic hypoxia. So that's how we find out. So the 100% oxygen test can help in hypoxemia and also in hypoxia. But bear in mind, as I mentioned, these can coexist. In many a time in clinical situation, when we see a patient in ICU or OT or in ED, in the ward, this not stand-alone cause. It is mostly a mixed causes. So this is just for us to understand, then we can interpret it as a whole picture. So when we look at it, in hypoxia itself, the PaO2 will be low in hypoxemic hypoxia, but in anemic, circulatory, and histotoxic will be normal. Or sometime in histotoxic hypoxia, the PaO2 will be high because reduced utilization. The oxygen that is delivered in the arterial into the cell is not being used, so it will be on the high side. There is no usage of oxygen, so it could be high as well. The causes, hypoxemia, I've talked about the 5 causes. Low FiO2, hypoventilation, dead space, VQ mismatch or dead space, shunt or diffusion limitation. So what we can do, we can increase oxygen supplement. It will help in 4 causes except the shunt. In anemic, causes could be anemia that causes reduction in hemoglobin, bleeding that causes also HB to drop, any bleeding disorders causing malfunctioning hemoglobin like methemoglobinemia and everything, or carbon monoxide poisoning, which displaces the oxygen from the hemoglobin, causing hemoglobin malfunction. So we treat the anemia, the causes of anemia, you transfuse blood in bleeding or increase the hemoglobin level, or hyperbaric oxygen in carbon monoxide poisoning, because we talked about how hyperbaric oxygen can increases your partial pressure oxygen that in a dissolved plasma, because hyperbaric oxygen is at a high atmospheric pressure, which will increase your partial pressure of alveolar oxygen very high. In depth PaO2, your dissolved concentration of your oxygen in the blood will go high, very high. So that can be help in carbon monoxide poisoning. And very high partial pressure of oxygen also will displace the carbon monoxide from the hemoglobin. Next, circulatory hypoxia, which is all because of shock. So we have to identify what type of shock patient is in, and then we have to treat accordingly. Finally, histotoxic hypoxia, most common cause is cyanide poisoning, which causes inhibition of mitochondrial cytochrome oxidase. Okay, that is the enzyme that involved in your electron transport chain. Where cyanide inhibit your mitochondrial cytochrome oxidase, it will inhibit the electron transport chain. Thus, the oxidative phosphorylation fails. Your respiration switch from aerobic to anaerobic respiration. So treatment will be antidote for cyanide, will be hydroxycobalamin, your sodium thiosulfate and everything. I'm not going into detail. And also hyperbaric oxygen also, there are some literature say can be used, but hypothetically it can work, but that's why I put an asterisk here. Okay. 4 types of shock, just a sightline, just a completion sake. You have to know 4 types of shock: hypovolemic, distributive, cardiogenic, and obstructive. Hypovolemic, as the name, hypovolume, the volume issue, blood and fluid compartment. Distributive is in the vascular vessels, the distribution of blood flow. The circulation impairment is because of the distribution of the circulation. Cardiogenic is the pump itself is the problem. The pump is not pumping enough flow out of the heart. And obstructive shock is also again to the circulatory system. There is problem to the circulation because of the blockage in the vessels. Okay. So the shock can be hypovolemic, cardiogenic, obstructive, and distributive. I'm not going to discuss this in detail, but I'll share this slide. I've talked about what is this. So you have to, just one thing I want you all to bear in mind or remember. Hypovolemic shock, you all know, it's obvious. Cardiogenic shock is the heart problem. Obstructive shock, you all know about the problem. Can be pulmonary embolism, tension pneumothorax, pericardial tamponade, whatever that is causing cardiac output to be obstructed. The ejection, the blood cannot be ejected from the heart easily. Okay, there is a resistance to it. But distributive shock includes anything that results because of peripheral vasodilation. So your septic shock, anaphylaxis, and neurogenic shock are not stand-alone. They comes under the broad heading of distributive shock. So when you go for exam, when somebody asks you to classify types of shock, don't say septic shock, anaphylaxis, or neurogenic shock. Your classification is only 4: hypovolemic, cardiogenic, obstructive, and distributive. Your septic, anaphylaxis, neurogenic, all of the same pathophysiology or peripheral vasodilatation. So thus they comes under the distributive shock. Because many times when I ask for Viva or ask my candidates, can you classify shock? Or they will tell about hypovolemic shock, septic shock. No, that is not classification. Classification is hypovolemic, cardiogenic, obstructive, and distributive. Example of distributive shock is septic, anaphylaxis, neurogenic. Like example of cardiogenic shock is MI. What are the reasons? Clinical situation where you can get cardiogenic shock. So clinical situation when you get distributive shock is septic, anaphylaxis, and neurogenic or spinal shock. Hope this is clear. Okay, we go back to hypoxia. This slide is to show, since exams can come out in MCQ, what are the changes in the blood investigation or ABG investigation you can say to tell what type of hypoxia is this. In hypoxemic hypoxia, the PaO2 will be low. Okay, the PaO2 will be low if it's a standalone. If it's a standalone cause, not a mixed cause. Okay, if it's purely hypoxemic, the PaO2 will be low. PaO2 low, of course, SaO2 will be low. Because of PaO2 and SaO2 low, we know oxygen content equation, the CaO2 will be low and the arteriovenous concentration will be low or normal. This is AB. Differences between concentration of oxygen in arterial versus concentration of arterial venous. We have discussed about this with examples in the first few classes. In anemic, the no problem with PaO2, SaO2. The problem is with the hemoglobin. Thus, the content will be low. When the content will be low, the differences between arterial and venous content also will be low. Okay, this is concentration of oxygen max lah. Okay. Then circulatory hypoxia, there is no problem with PaO2, SaO2, CO2 or CaO2, but there is a problem with the flow to the thus, as I mentioned, because the flow is less, the oxygen extraction will be very high. Whatever that oxygen being supplied in the arterial system, because the flow is lesser, the more oxygen will be extracted in the cells. Thus, there is only few oxygen left in the venous system. Thus, the difference between the arterial and venous oxygen will be increased. So you take a venous blood gas, you take an arterial blood gas. If you find out the oxygen content, you do a calculation. After you have to do your oxygen content for arterial and oxygen content for venous. If the content is increased, then we say it's a circulatory hypoxia. Then we'll find out to histotoxic hypoxia, but there's no problem with any of these. As I mentioned, because reduced utilization of oxygen, the PaO2 may be raised or normal. But again, because of the because of the differences in arterial venous, the PaO2 will be on the high side. The content of arterial will be on the very high side because of defective utilization. The differences between arterial and venous oxygen content will be either reduced or normal as well. So it's very difficult to actually calculate this histotoxic. Histotoxic will be by looking at all the others are normal, means most likely is histotoxic. So what are the clinical effects of hypoxia and hypoxemia? Can come out in MCQ or Viva for you to know. So hypoxemia, what they will do? They will stimulate the peripheral chemoreceptors to increase your respiration and increases the ventilation. It increases the pulmonary vascular resistance because of hypoxic vascular HPV, hypoxic pulmonary vasoconstriction. Stimulate your hematopoiesis to compensate. As I mentioned, patient may develop hypoxemia, but if it increases your hemoglobin level and increases your flow, your blood flow, the patient won't develop hypoxia because the oxygen flux is maintained. Alters afferent nerve skeletal muscle activity and produces muscle fatigue. It means your reduction in your oxygen, and then alters metabolism, causes glucose tolerance. These are all subsequent effects of hypoxemia. Hypoxia, as we know, is at the cellular level. It disrupts normal cellular function, inhibit glucogenesis, metabolism of glucose to ATP. So less ATP will be. Aerobic respiration produces high amount of ATP. So it will switch to anaerobic, will be low amount of ATP. Promotes anaerobic glycolysis, increase in lactate production, non-volatile metabolic acids. Because of anaerobic respiration, hypoxia, patient have a retarded CNS function, blunts cognitive behavior, advanced tissue organ dysfunction. Patient goes to multi-organ dysfunction and cell apoptosis. So summary, this is the full chart which I found online, which is very good as well. I will share this. I'm not going to repeat all this. I'm just going to put it here. I will share this to you all. You can keep it as a quick reference in your phone. Next topic, we will talk about Shunt equation and VQ mismatch in detail. That's all for today. Any questions before we end our session?